said there's not too many people on the line, so it's probably pretty safe to just say that.
Well, we now have 100, no, 12.
Well, you know what? I would say it anyway. I'd shout it from the rooftops.
The Toronto Star is online now. Watch it.
Yes. Oh, dear. So Frida's on, Heather McConnell. Is Heather Woodbeck here? We should wait for her, right?
Yeah.
Wendy, Rebecca, oh hi. Going from Zoom to Zoom, eh?
Mhm.
Okay. Okay, well, let me open the session, and I want to welcome the 23 of you and growing who are around.
How is everybody?
Oh, here's Doris. Fabulous.
Yeah, excellent.
Okay, you always pick the exact right time, Doris. Very good. So I'll turn things over to you to open, and we've got an agenda, and yeah.
Fantastic. How is everybody of our colleagues? I want thumbs up, thumbs down. Let's
They
see.
haven't got their videos on, Doris.
Yeah.
But
So they cannot tell us.
Well, they'll chat. They'll put their comment in the chat, right? How's
Okay.
everybody? Let us know.
Let us know. How are we doing? Can you hear us?
Yes, we can.
I like the good. I need more goods. Great.
Yep, good, great. Tired, exhausted. Yep.
That
Yeah,
energizes
exhausted.
me.
All good, thanks.
Oh,
Yeah.
thank you, thank you, thank you, thank you, thank you.
Yes, lots of goods. People are making the best of it.
Good.
That's
Hi. Yep.
excellent. So let's get moving.
Yeah.
I want to hear also from our colleagues say yes or no simply if you will be working, whether virtual or in person, in your homes during this Friday, Saturday, Sunday. I want to hear. Yes.
Yes.
Yes. Yes. Anybody that is a no? I wish I was a no.
Yeah.
Nobody's a no. So listen, guys, just so you know, we are working too. So if you need anything, absolutely anything, are you all in WhatsApp? Let me ask that first. WhatsApp? Yes, no?
Yeah, the chat.
Yes? No, yes? The rest? A yes and a no? Okay, let's do this. Take my number. You can enter me in WhatsApp, and then you have my email. If you need anything during these 3 days, we need test kits. You will get test kits. I will talk with you about that in a minute. But take my number and take my email because I also will be working. And I know that Daniel and some of his team will be alert in case you need staffing. We are not abandoning you. We are with you. So please take the number. I don't know, Heather, if you can write it on the chat or how do we go?
Yeah,
about?
we can write it on the chat.
Okay, +1 647 505 1531. So 1-647 505 1531. When you write to me, say, I am Jean, I work in XXX nursing home. I'm Rebecca, I work in this nursing home. And those that are not on WhatsApp, please email me if you need anything. It's D Greenspoon, if you can write it, dgreenspoon@areneo.ca. If we can write it on the chat.
Heather, can you write it? All of a sudden, my print has gone baby, and I don't know.
No, I'm doing it right now. I've put the phone number in there, and I'm just putting Doris's email address in there.
Excellent. And anything you need, just shout. I do monitor closely, and I'm many ways working. So here you go. So let's talk about updates. So updates, I don't know how many you heard from the government and the new guidelines, and they will be all on my report, which is going out momentarily at around 8. And the reason we cannot send it before, just so you know, is because we actually, before that, are deploying nurses. We are deploying nurses, RNs, nurse practitioners, and PSWs to the various nursing homes and to other organizations, hospitals, etc. So it's the same system, so we cannot double do it. Otherwise, one gets delayed, and we decided that it's more urgent that you get all those resources on site than actually getting the report. So that's what's happening, okay? So several things that are changing as we speak. Nursing homes, universal masking, as Aurelio has been asking for some time. Now, the fact that you got the directive does not mean you have the surgical masks, but anyways, that's important. Just 1 second. Sorry, I needed to say to my grandkids that are on the line with my husband that I can't focus on this if I hear them. Some things take me out of focus. That's one of them. We are doing virtuals all the time with them. Not all the time, but as much as possible. In any case, so the universal masking is already in place. Let's see, and I want to hear from you if in your homes you will fall short of them, because then we will escalate. And Heather, if you can send that list to people again of the 5 regional PPE coordinators for government, that will be great today. And then the first thing you do is you write to your regional, to the Ontario Health Regional PPE lead, no mask, or I am 1 day out of being short of masks, etc. And we are talking about surgical masks. We're not talking about N95. I know that ONA signed an agreement that in hospitals, nurses can, if they choose, ask for N95. We at RNO are urging everybody to continue to use the protocols for that. Those are protocols that are being used around the world and are used according to the situation with basically how the virus gets transmitted or not. If we all start to use N95 everywhere now, we will not have N95. It's as simple as that. So let's keep the N95 to those colleagues that will be doing tracheostomies or next to ventilators or with patients when you are doing a test, that they can, you know, do. Let's be smart how we use. That's not to, so that's what they will be sending to nursing homes. Second, the piece that is ramping up significantly in huge numbers next is the issue of testing. And that's another component that RNO has been pleading to the Premier directly. And the Premier, you heard him 2 or 3 days ago saying that he was losing his patients. Well, we lost ours some time ago. So testing is critical, and testing is not only important to determine if a person is COVID positive. Testing is important also for surveillance to prevent that the fire is in-house actually. So you will see that ramping up, and you will be receiving then testing kits, etc. But if you do have residents with symptoms, raise your hand and write to me, because you absolutely should be getting that immediately. Those are the 2 components that are very critical from the province perspective. From our perspective, you got from Heather and the long-term care coordinators the guidelines for self-isolation. Maybe Heather, we can attach alongside with the,
we'll send all the doors.
I would attach again, Heather, or indicate to people, can people put the phone on mute? Can people, Can you mute people? Because I can't hear.
Yeah.
So I suggest that you indicate to people where is all the guidelines and all of that, so people can, just because every time is not the same people participating, so that will be very good.
Yeah, we'll
So there
upload
is-
them onto the site, Doris, and then we'll send the link again.
Fantastic. So there is the guideline on self-isolation, there is the guideline on palliative care, there is the guideline for mental health support, etc., and other pieces that Heather will update on how people are using the Via Family, etc. So if you are short of masks, more than, let's say you don't have you have only for 2-3 days, let us know. We need to put the phone on. Okay, thank you. The mask we
And
need
in
to
the
know.
chat box, I did, but then I can't see the rest of them, so I don't know. Don't know.
Okay, I cannot talk over people, so I'm going to wait. I don't know what's going on. Are we good?
Yeah, we're good.
Okay, so the surgical masks, the testing if you need because you have someone suspected of COVID, the guidelines that Heather will resend, the link, the Via Family that is for people, for families that need support and is monitored by our long-term care coordinators. And lastly, the Via Nurse if you're short of staff. Let me repeat that this is for RNs, for nurse practitioners, and for PSWs. And within hours, Daniel and Kerry and the team that is in charge of this will release staff for you to be able to augment the staffing in the homes. So this is very important. This refers to 2 sectors, nursing homes and retirement homes, okay? We have also made huge progress in the area of people that live in shelters, but I'm not going to get to it now simply because of time. And we are making significant headways also in indigenous health persons. All of those are areas that RNO is simply taking on as a priority areas. Let's do, Heather, if you don't mind, let's open for questions first to see if people have questions on these issues. And then we can go around identifying challenges and solutions. And then at the end, if we have time, you can update us on how people are using the Via Nurse and the Via Family, etc. Heather?
Sure, Doris, actually, we have a couple of questions that came forward since our last meeting. And so we could start with those and then we can do a round. Would that be okay?
Fantastic.
Yeah, okay. So just to let everybody know that, again, in follow-up to our meetings of last week, we responded. So the documents that Doris has just spoken to are on the NP, are linked to the NP page that Kyle has created, and they're all available for you. They're also on the RNO's COVID website page, but we'll send those out to you again. And again, we've worked through these and the development of these through our long-term care best practices team and supported through Advantage Ontario and feedback from others. So hopefully those will meet your needs or at least address some of the issues that you were looking to. And again, in self-isolation or isolating patient or residents in long-term care, end-of-life care, and mental health and well-being resources. So the other thing,
the other area, just so I don't forget, Heather, if you're running low on palliative care, on drugs related to palliative care, please, 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 if you cannot succeed to get that through your local hospital or through whatever, do let us know too. Do let me know. That's totally, do not wait even a day on that. Yes, Heather, sorry.
great. Okay, so Kyle, if you guys move to the next slide. Oh, can I? Yeah. So just to let you know that there are webinars happening all weekend on managing residents' death in long-term care with the chief coroner. And these have been advertised and working through with Advantage Ontario. So they're actually having them starting tomorrow right through Friday, or sorry, right through the weekend into Monday. And this you can find on the Advantage Ontario website as well as others. So I can send it, we'll include the link, I'll put it in the chat box. And basically this is about dealing with resident death in long-term care homes and being able to answer some of your specific questions. So certainly they're encouraging individuals to attend. So I just wanted to make sure that you were aware of that. If you haven't seen this information, it'll be important for your practice. And Kyle, if you-
Heather, do you know if they're going to record them, that we could post them in our
I couldn't tell, Doris, but I will look while we're on the call today and see if I can. And by the end of the meeting, I'll let you know.
I can ask Dirk.
Well, I
know him
unmute it, but it doesn't bring their voice in.
Okay,
I
Dirk,
know
okay.
Dirk well, so I
Okay.
can ask him directly, because
Okay.
I think that will be important. I will
Yeah.
take that on.
Okay, super.
I will
Thanks, Doris.
give you
Yeah.
so you know, yeah.
Okay, so that's again just in follow up to some of the issues that came up at last week's. We recognize that this might be useful information for you. So we did have a number of questions that have come forward since our last meeting, and some of them may be related to what Doris just mentioned. So Kyle, if you could just go to the next slide. I'm sorry, I don't know if I can. Yeah, so we had some questions around, or some issues or statements around medication shortages and how are these being addressed. And it wasn't really clear from the message whether or not, or the question whether or not it was medication shortages in general or more related to palliative care. So we'd like to get your input. Now, if you're able to unmute, you're welcome to, or if you want to chat and type into the chat box, that's fine too. But is this something that you're challenged with right now? And how are you addressing it in your practice? I'm not seeing anything.
Hi.
Oh, go ahead.
It's Wendy. It's Wendy
Great.
Dunn.
Hi, Wendy, go ahead.
I guess what I've seen is shortages in all different classes of drugs. I think it's just all across the board, like blood pressure pills to, it's almost every day, a couple times a week. So what we've done is they just suggest what they have and we change it out is
And
kind of the way it's working.
The other thing, Heather, and Wendy, we should treat this exactly the same as surgical masks and test. If you're running short and you cannot change it, let us know like 2 days in advance, because we should push that.
Yeah.
Excellent.
Good. Anybody else have any comments about this one? I'm just looking.
Hi there, it's Shannon. Can you hear me okay?
Yeah, go ahead, Shannon.
I'm involved in the Southeast Lynn, and we've just had a meeting recently, and our plan is if we have shortages within our pharmacies at the long-term care home, OMS is going to be helping us in providing COVID kits, palliative care kits that we could access through them. Typically, they don't have as much to do with the Lynn in terms of our pharmacy needs, but they're going to be helping us out with those shortages.
Okay, super. Thanks, Shannon. Anybody else have a comment about this one? How are you managing this in your particular practices?
Heather, maybe to the individuals that ask in particular those emails, in addition to what we heard, you can then send them a private email and copy me.
Sure, yeah.
Just in case they're not here, so we respond to them. And I can address that also in my report tomorrow.
Okay, so the next question or statement was an issue related to test results of staff. And what appears to be happening, and this is more of in relationship to staffing issues. So right now what's happening, of course, is that staff that need to be tested are tested and their results go to public health, and then public health communicates that to the individual receiving their results. And of course, that's very appropriate based on, personal health information. But what public health is telling the staff seems to be maybe not consistent in terms of what they need to do related to self-isolation if they've got something other than COVID. And so this is causing a great difficulty because staff are telling their employers that the public health has told them they need to self-isolate for 14 days. And the employer or the long-term care home isn't able to actually verify that. And so this is more of a systems issue that I think was just being brought forward as something that is causing some of the issues related to staffing.
Yeah, but that's same in regular times, right? When, I mean, any of us get a letter that the person will be off for whatever amount of time and you have nothing to do but just take it. So I don't know that that will change in any way. I don't know. You know what I mean? You will hope that if person self-isolate for 14 days, they're doing it because of COVID, not because. But I'm afraid to tell you that we may see some of that as a result of the next item, which is right to care, right to protect.
Oh, I just,
Because-
sorry, Doris, if we could just go back to that first, the second point, what Holland Christian Homes is struggling with is that the staff are reporting to public health that they have worked with somebody who has COVID, and therefore they are being told to isolate at home and not come into work.
And that is not the case, you are saying.
Well, the PSW who was COVID positive, it is the case, but the whole home, the staff have gone off, or not the whole home, but pretty much half the staffing have left because they had contact with that staff member that day. So now they're isolating.
Yeah, and that's what the public health unit will tell them to do.
Yeah.
So actually they are right. So the issue is then you need to fill in using Via Nurse.
Yeah.
The whole point of self-isolation is to prevent further spreading, right? So yeah, whether it's a staff or a resident, it is COVID plus.
So if a nurse works with a COVID plus resident, they can't work tomorrow?
If a nurse is, well, if the nurse is without PPE, should be
Well,
with PPE, right?
Yes, there hasn't been enough PPE.
Well, this is what's going to change, but this is why we are in the mess that we are. I mean, I'm not saying it's the home, it's the system is the problem, right? The whole problem is that we have been reactive to after an outbreak, and even after an outbreak, not always the homes have the right supplies, but that, I am told, will change.
But wouldn't the nurse that has been working with the COVID patient be tested? Like they
Well,
need
you will
if
not
you
show
can.
symptoms right away in
right
Medina.
away, I know.
Yeah, I know. So let's follow the guidelines, please,
Okay,
and let's not
Okay.
start to guess the evidence.
yeah. yeah.
So
Um,
it is
can
what
I-
it is.
One
It
of the
is-
things I just wondered about was I've heard people talk about they're being asked to be put on work, or they're being put on work isolation.
Well, which I think is horrible.
Yes, I mean, I don't know quite
So
what
this
that
is for the so-called essential workers, but that's not an entire group of people. That cannot be all your PSWs and all your
No.
net, because that's what you're seeing the results, right?
Yeah.
So they measure temperature twice a day and all of that jazz, which is not proving, of course, to be effective, because you
Mm.
know that people can be asymptomatic and can be shedding the virus to others. The whole point of self-isolation is not to expand the exposure and the growing numbers of people COVID positive in a
Right.
resident. Yeah. So the guidelines are there, and today there were added guidelines that you will see tonight when you get the report, because there are new guidelines for health professionals. And if anything, they're more strict, not less. Because now we have a lot of more testing capacity, it will be more and more strict. And one piece that you should be looking that will come sooner or later, and RNO is definitely pushing for it, is the issue of working only on one place, which should have happened a long time ago, right? And so if you don't have enough PSWs, basically the ones that you will keep need to work full time rather than having many part-time. And in another place, they will keep another group full time, and etc. And if you're still short to use Via Nurse, via PSW, well, it's called Via Nurse, but there are PSWs there too.
BC took a position this week about that.
Excuse me?
BC took a position about
Oh,
that this
BC
week.
took a position, no, BC took a position about 2 weeks ago already.
Mhm.
Yeah,
He has been doing this at least, that's why BC doesn't have the spread. They started with spread, but then very quickly, they catch up into testing, into mass, universal masking, into one employer. So you can see, I have been quoted extensively in the media. I was in the agenda on this, and we have been on record on this. The guidelines have not changed, but expect that they will.
All right, it's Deirdre. I'm just wondering, have you heard anything about PSWs having their wages supplemented by the government.
So what we are saying from RNO is PSW, any worker, PSWs included, need to work full time in only one place. That's it. So then you don't need to supplement income. It's full time, right? But if a home wants to keep someone part-time, still needs to be in one place, and then you will need to augment or someone, government, BC, by the way, is augmenting compensation to full time.
Yes. Yeah, and I thought that was a really good idea because
Well, it's a better idea to put people full-time in one home and then do augmentation of compensation. Otherwise, everybody can work part-time and have a full-time salary. And that's really nice. Right?
And then that prevents, it reduces the human resource capacity.
Exactly. Okay.
The right to care, right to protect.
Or any more questions about staffing first?
Well, Doris, there's one thing I didn't address yet, is in many institutions also we have clinical nurse specialists or are APN who are not nurse practitioners who are dealing with this issue, and they're not invited here tonight. So I know because we have meetings already last week with the clinical nurse specialists, and we're having another one tonight talking about issues.
No problem. Feel free to invite any CNS that works in long-term care. Not a problem.
Can the email goes to also CNSs?
Heather will take care. I really don't get into those details.
Yes, we'll
because in many cases, they are the one implementing the guidelines for the infection control and so on.
Very good. Okay, any more questions on staffing? Okay.
I
Yes.
thought someone had referred to right to care, because that you're talking
I will talk
that as
about that,
well.
but
Okay,
let's first do anything else on staffing.
I know in some cases we've been supporting the facts that if they are short of PSW, that they are hiring RPNs. And I said, go for it.
Go for it, absolutely, but there is plenty.
Than unqualified.
Absolutely, yes, but there is plenty of PSW still in RNO if people need. So, I mean, I leave the issue of who you staff to the nursing home. We are not going to intervene what they do.
In the regions, it's a different problems. That's what we're encountering.
Yeah, very good. Okay, anything else with staffing? Excellent. Let's talk about right to care, right to protect. What's the question there, first of all? Do you understand what the concept is? First of all, absolutely every nurse, as every doctor, as everybody that is a health professional, has signed on the dot that we will work with patients. We don't just leave patients. What this means, though, is that we are also asking government that they need to protect the healthcare workers. Right? That's what it means. It doesn't mean you abandon patients. It means that, yes, there is the duties, not the right. So the way I call it is duty to care, not right to care. Heather, if you can change that.
Sure,
I wouldn't want this posted even that way.
Yeah, no, thank you. Yeah.
Actually, and it's duty to care and duty to protect. Yes, you're right.
Yeah, that was me. Yeah.
No worries.
Yeah.
So it means absolutely we have the duty to care, and RNO is saying government has a duty to protect. And I say government because the employers don't have the means. Now, that should not ever leave employers off the hook. So we should say governments and employers, because we are aware of some situations that absolutely the issue is with the employer, very critical issues that we are dealing now and that need to stop. And we are taking care of some of those issues, i.e. putting, if I may, Paul Andre, PG, can you please put, or whoever is dealing with this, can you put mute? It's very difficult when one is tired to be interrupted. It's difficult. I'm extremely tired. So the issue is this. When someone is being asked to do something that it goes absolutely against infection control practices, please call me on the spot. Do not leave your work, do not whatever, don't do what you are asked, but call me on the cell. Because if someone is being asked to put someone from a hospital with COVID positive, with a client that has nothing, that is simply absolutely not only unethical, it's against any infection control practices, and you should never be put in that situation, and we will guide you to that, including speaking with the employer. If people have difficulties finding ways to self-isolate people, Heather and the LTC team developed a fantastic guideline with many ways to do that. Put 2 patients that are COVID positive. If worst comes to worst, put a suspected COVID patient with a COVID positive, but never put someone that has nothing, which is what I have heard with a COVID positive patient. We are inviting simply for the other patient to be on the same situation. So it's very, to me, it's traumatizing, to me personally, it's traumatizing that we told families to stay out of the nursing homes to protect their loved ones. And yet we are not protecting them. And I'm not saying this, that the NPs are not protecting, I'm saying the system is not protecting them. So at the end of this ordeal, we will have more and more people, residents dying, no doubt in my mind, unless we get ahead of the outbreaks. And that's what today, read the article, it will be in the piece from Moira Walsh. She quoted me of saying, some word that I said that is a big word. It is big, and I never thought it will be quoted, but a carnage. I said it's a carnage because it is a carnage. Because the reality is that we need to get ahead of the outbreaks and not start to do all these things that we do with universal masking, testing, etc., self-isolation after there is an outbreak. It's like, we don't do that with anything else. Why are we doing that here, right? And we don't have a vaccine, guys. The vaccine is testing, masking, and self-isolation. So this is the issue here, and that's why we're pushing on the duty. If you can change that slide because it's soaring on the eye. The duty to care with the duty to care, and I will write it, please, Heather, with words, because this will be posted and I don't want this to be spinned out wrongly.
Yeah.
It is the duty to care must be matched with the duty to protect. That's what it is. So, Paul Andre, I think you had a question or a comment, or
My comment is about the employers who are putting under the lock the PPE, and they are giving it at a little drop at a time. I know the government said that they're going to be telling the employers, but the employers need to act on it. And I don't know what pressure the government can put on them because the staff feel quite unsafe.
So the issue is this: if there are not enough masks and masks disappear, and that is a reality too, people take 2, 3, 10, 15, 20 and take them outside of the organizations, and that is happening, then this is why employers are doing it. And I do not think that they will, even when they get enough supplies, there is not an extra supply box. So someone needs to be in charge of that key 24/7. And if you are soiled mask, which you are given, this is what we are asking, to give 2 of these a day, no more. If that gets soiled, then you will give the soiled mask and they will exchange it. This is the way it's in hospitals and everywhere else because there is an international shortage. Let's do round table. Maybe Heather, you can call names and just to see that everybody gets a chance, please.
Sure, I'll try and do that. Let me just see if I can figure that out. Okay, I don't necessarily have everybody's name, but I think we've got Beth Sweeney. Beth, do you have any questions that you'd like to have addressed? Any comments?
No questions, but thank you for everything that's being done, and thank you to all my nurse practitioner colleagues. Actually, there is one. So if you're an NP and want to give a little bit more time. I wonder, because are NPs expected to work as RNs with the call out via nurse?
No, NPs work as NPs. RNs work as RNs.
Hello, it's Wendy. Wendy Dunn. I'm in the
Yes.
middle of a COVID outbreak, Doris, and I work as a PSW. I
Well,
work as a PSW, I work as an RN, I work as an NP,
Yeah,
and I work as
absolutely.
a physician.
Well, absolutely,
Because
but I
our
think
physician hasn't walked in the door since we went into outbreak.
I understand, Wendy, but I was answering a very pertinent question. of-
Okay, but that's the reality on the ground.
Yes, no doubt, no doubt.
So I just had to say that.
Yeah, yep. All of us are working in many things. I'm working with all disciplines more than ever in my life, on policy issues, on supply issues, on planning issues, on you name it issues. That's
And
the,
I thank you greatly for what
no,
you're
no,
doing
no,
up
I
there.
understand what you're saying totally. And I'm
Yeah.
sure also
Mhm.
you're working short on top of
Oh,
that.
yeah, and that's
And you
like
may be
it's,
even, and you may be even working as a cleaner, because actually
Yeah.
one of the areas where
Yeah.
we are most short is
Uh-huh.
actually cleaners in nursing homes, which
yeah.
is a recipe for disaster.
Yeah, so I've actually started processing my own orders. I actually put all the orders in Point Click Care if I change anything. The nurses do not have time to do one extra thing. I've decreased all the med passes to 1 pass a shift because they, except for the ones that really, really can need the 2, like your Parkinson residents or pain that you can't manage any other way. But it is, the workload is above and beyond anything I have ever experienced since I graduated, well, since I've nursed, since
So Wendy,
1990.
couldn't you bring more people? Like,
Oh, we hire 3, 4 a day, but then you've got to orient those people. Like you can't just step them into
Yeah.
these homes. These homes
Yeah.
are complex.
yeah,
Mhm.
yeah.
It's,
Yeah.
and
yeah.
that takes time and energy. And then you have 4 people call in saying, I can't come in,
Mhm.
right? 4 full-time staff we had today call and say, I'm not coming back. And you're like, what? You're not coming back? That is the reality. Like, and you
Oh, I
can't just,
believe that. I
you
believe
can't
that.
keep replacing full-time staff with staff that do not know your residents out here.
Mhm.
Doesn't
Yeah,
work.
but Wendy, if not, you will choke. You got
Oh, I
to.
know. Oh,
You
and we
got
do.
to, you got to.
Yeah, we are, but that has blown me away is that staff don't come. They say, and it's
Well-
not the registered, it's the PSWs, right?
Well, because they're super afraid.
Yeah, and they don't, what do they
Remember,
get paid to do
Wendy,
this?
the less education you have, the more afraid you get.
I know, but what are they paid to do this? If you think about it, right? Like pay me what, 20 bucks an hour to be front line. Like they're the risk.
Yeah,
It's not the NP. Well, it is because I've done all the swabs, but right? Like it's,
yeah.
that's the
Yeah.
sad part of our whole situation. Your ICU nurses will show up. Your
Yeah.
PSWs are scared
Yeah,
and they get paid 20 bucks an hour to
yeah.
do this.
Yeah, well,
And
I
then the
believe that,
docs,
I believe,
the
wait,
docs get a
wait.
raise. Why are the
I be-
docs getting a raise?
No, but also the PSW got, let me check on that. I'm pretty
Oh,
sure that they increased
I'm
to
sorry.
22.
I'm at the end of like day 8 and I've had 1 day off and it is work. If you can prevent, because once you're in for the long haul.
Yeah.
Yeah, so there's my tears. I gotta go, but good luck, everyone.
Wendy, can you send me, are you on WhatsApp, Wendy?
I have your email. I'm on WhatsApp with my family. Do you want to join my family? WhatsApp?
No, but you can,
No?
you can still send me, no, but if you're in WhatsApp with your family, you can still send me a WhatsApp.
Yeah, I don't know what you want. I don't know what I'd say. I
I
called
will
out
tell
to
you,
Sue
I will
Sweeney.
tell you after, just WhatsApp
I love
me.
you, Doris. I called out to Sue Sweeney. I did my big help
No,
the other
send me
day.
a WhatsApp and say, I love you, and I will tell you what I want to ask from you.
Okay, I will do that.
Thank you.
Okay, I gotta go.
Doris, Wendy, are you
Yeah?
gone yet?
Almost, not yet.
Oh, it's Linda Anderson.
Oh, hi, Linda.
Hi. I empathize with your situation because we're not that far different in Exeter Villa in Exeter. And I do want to say, I appreciate all your support for every other interdisciplinary person you're working with. However, I really do think there is some benefit in focusing in your lane as an NP and making sure you get those high-level skills in place for all the residents that are depending on you, especially when the physicians aren't there. And I understand the shortages from the different disciplines, right from all the registered staff to the PSWs to every other discipline. And you get pulled in multiple directions. I'm living it with you. And I think it's a difficult challenge to balance what you need to do for the benefit of the resident, because I truly believe in our assessment skills and being, you know, in there for the residents, especially when the physicians aren't there and you have multiple people to manage.
So Wendy, Linda is echoing what I said in a much more eloquent way. Try to bring people. I know it's choking for you, but if not, you will choke completely, darling. It's impossible. And your residents will not have what you can give them.
Yeah, no, I'm actually doing okay. I do very well when I'm out there on the floor. And what I do is I go in and I feed the residents that need my skill level for assessment is the way I do it, right? So I'm doing what I need to do. I am just supporting them as I do it and not creating more work, which we all know is not what they need. So I think I'm doing okay when I'm on the floor. I'm just ranting. I'm ranting to a
I like the rants.
Yeah, and that's what this form is for, Wendy. Yes.
There you go. So thank you for listening.
Thank you.
Thank you for listening.
And
I'll talk to you later.
Send me a WhatsApp.
I did. I said hello. I didn't say I love you, but I'll send that too.
That's good enough. That's good enough. I will say I love you. Here you go. Thank you. Thank you.
Okay. One of the things I think that's important to say is with the Be a Nurse, it's the nursing students who are acting in the PSW role, and they are really very willing to be in this role at this time. They're second, third, and fourth. So you are getting a really, I think, dedicated, committed, and very interested student who's very anxious to be involved in a good way.
Very good. Heather, can you mute and unmute the person that you want to talk next?
I can't do that, but I can ask Beth Sweeney, who's next on my list here, to see if she had any comments.
You already asked her. Next.
Beth, did I? Okay, no.
Oh, Beth, did your question actually get asked? Oh.
Next.
Okay,
Next,
Claudia?
yeah.
Claudia, do you have anything that you'd like to ask or share with the group?
Claudia did have a couple questions in the chat box.
Okay, thanks, Cal. Go ahead.
So the first one was, should we be doing annual physicals for the physicians who are not physically visiting the homes? We did get a couple of responses from some of the other participants saying that they're putting their annual physicals on hold.
Absolutely, 100%. 100%. This is not regular times. I mean, if you don't have an outbreak, let's be clear, if you don't have an outbreak and you're doing well, make sure that you are ready to have a place to isolate. Now prepare. And if you still have time, absolutely do the physicals, because we'll allow you to see how the patients are, the residents are, right? But first is get ready just in case, prepare for worst case scenario so you end up in a better scenario.
And as I think Doris has been saying numerous times, get on to Be a Nurse and build up your staff for surge, and then do that orientation before you're under pressure.
Okay, Heather, next, please.
Yeah, I think we've got Jean as next. Jean Benton. If Jean, do you have anything that you wanted to share or ask?
Jean, I've unmuted you, so please feel free to.
Okay, I try. It took me a while to get the system working tonight.
We can hear you beautifully, Jean. Go ahead.
I'm an old nurse, put it that way. I just have one question. at my facility, we have the luxury of have a separate unit for our COVID ill people. I'm still battling that if it's a suspected case or a probable case, they need to be going over to that unit as well. There's a tendency for them to want to keep them on their units pending the swab results. And I said, I think they need to be off the unit and move to this section that we have that is separate. But my other question is, once we have COVID ill people.
So, sorry, so the answer to that, you are totally right. They shouldn't wait. They shouldn't wait.
Okay. Then my second question then, which bothers me a bit, is, well, a bit, it's when I'm trying to battle, is the assessment of the ill resident. They're putting forth a protocol or a process that it would only be an RPN going into the room to do the assessment, and then I'm to make the decisions. Let's suppose a person's really deteriorating and it's an issue of initiating the palliative, that I'm going to base that on what the RPN assessment is. And I said, no, I need to do my own assessment.
Good for you. End of story. Good for you.
Oh,
no one can dictate what you do as an NP. And you know what I mean?
Well, I just said I wouldn't feel comfortable basing it on an RPN assessment.
Nor would I, nor would I. It's palliative care, right? It's not taking the Tylenol because the shoulder is bothering.
No, that's right. And the other question is more personal. I happen to be over 70, so the management, I opted to stay at work, but I got called in and I've been sent home saying, you know, you're 70. And I said, yes, but I have absolutely no comorbidities and I would choose to be there. So I'm feeling very defeated, put it that way. I'm supposed to be.
Well, I think that that's inappropriate. That's ageism, because a 70 that is with no conditions and a 50 that is full of conditions, you know what I mean? So I think you should take it on.
Okay, thank you.
I think you should take it on, and if you need to use me, use me. And they will ask you to sign a note, sign a note.
That's fine.
Because they probably don't want to carry liability.
Okay, thank you.
Yeah.
Okay, next on the list here, and again, I'm not sure if they've got any questions or comments, is it looks like Martin M.
Actually, sorry, I want to go back to Jean. I wouldn't even sign a note of liability, because also a 30-year-old can get sick. Are they not going to pay the sick time after? Don't sign anything. Say that here is my clean bill of rights. I have nothing. You know, I don't have, and it doesn't mean nothing. You're talking about cardiac, you're talking about lungs, you're talking COPD, you're not talking about my hip hurts.
No,
you know?
No.
Yeah, so I think you say I'm absolutely fit, I'm health fit, regardless of the age, and I'm sorry, I want to continue to work, and otherwise I will call it ageism, and I will speak about that. That's what I would do.
Okay, thank you.
Okay, so I think Martin M's not here, so we'll go to Michael.
Can you hear me?
Yeah, we can. Go ahead, Michael.
I apologize. I know this has come up on the chat before, and I feel as an NP, I'm caught in the middle because of physicians not coming into long-term care buildings. As myself, I'm working in 2 different facilities. I have got managers in both facilities saying that I shouldn't be going back and forth between homes, RNs and homes saying I shouldn't be going back and forth between homes, but other physician groups, including Dr. Ian Gemmell, saying I should be going between homes. I feel guilty not going between homes because one home is worse off than the other. I just want someone or some organization to put the hammer down and say I can or I can't, because I just feel overwhelmed by the constant different associations and disagreement between facilities.
Michael, do you use WhatsApp?
No, but I will, because you sold me on it today.
Please do send me exactly the situation, and I'm going to take that to David Williams, because the reality is this. So doctors have moved a lot to virtual. Is it possible that in one of the homes you can do virtual and in the other physical?
Totally possible, but it doesn't make my suggestions aren't good enough right now because one home is upset that I would do virtual and not come in the home. The other home is mad if I'm going between. There's lots of possibilities. It's just that I feel that the docs can say anything they want. And I just don't feel that I have the same luxury in my position to say I'm doing this and not this.
And these are your two usual homes, huh?
Yeah.
Wow, this is an immensely important question. Send me a WhatsApp with the question. I will put that in my piece today. Really,
Okay.
I will add it. If not today, tomorrow. I see if I can add it still. It's a very important question. And I'm actually going to see if OMA has any guidelines on this, and I will get back to you. My recommendation, of course, would be do one virtual, do both virtual, if not. But if not, do one virtual and one physical. The ones that is worse, I would do physical.
Yeah.
Okay, thank you.
I doubt that is, from an Ateneo perspective, we are trying to say that people should work only in one place. So, yeah, but they send it to me and I will do more homework. My hunch is that Williams will say and Yaffe will say, absolutely, because you are considered an essential worker. You are one of those that should go even if you're sick and just measure your temperature, which I will be absolutely horrified if you tell me you will do that. Yeah. Thank
Okay,
you.
we got a few more people here, Doris, and I'm hoping I'm not missing anybody, but we've got Sarah, Sarah next. Sarah, you? I'm not sure if she's able to get off of herself off mute. So maybe we could go on to Shannon Warner. Shannon, do you have any questions or comments that you want to make?
Shannon, I'm trying to unmute you. So just, you can, oh, there we go.
Oh, there she is. Yep.
I'm pretty new to Zoom and I put myself in a view where I could not find the microphone to say.
That's okay. We're all learning this week, and I'll tell you that there's lots of features that you didn't know were there. So go ahead.
You look like the Brady Bunch now. I don't know what I did, but anyway. No, I've actually been really, really pleased with the support we've got. So I'm on an NLOT team. We cover, I'm covering 5 nursing homes in long-term care, and we're an ER diversion team. So we've been really limiting our care to true ER diversions. We usually help out with a lot more than that. But casts, suturing, that type of thing, anything to prevent people from going to the hospital, and trying to limit the number of contacts. Typically I go to 3 long-term care homes in a day. That's certainly not happening at all anymore. So it's been quieter in that aspect. And then I'm trying to help out with some virtual care, minimizing med passes, helping with contingency plans, trying to help prepare these homes for a COVID outbreak. So the work I've been doing has changed a little bit, but we've had excellent support from public health. I think the peer support has been incredible. Everything's been really, really good, thankfully for me. So yeah, no, so far so good, but I know it'll be here soon. And yeah, I'll be leaning on all of you for help with that. So I thank you.
Make sure that you are ready now. The more you're ready now, including supplies, including testing kits, if you can have some, whatever, right? And the isolation.
Yes, it's and the one thing that I've been really happy with public health. So my son was sick, he was febrile, my husband was sick, and they actually swabbed my family so I could return to work safely. And that doesn't actually meet the typical screening criteria. So I was really pleased with public health for offering to do that. I thought that was wonderful.
Yeah.
Well, they know you're essential to be out there.
So make sure you also educate the staff well. So the staff are ready and don't panic when there is a case. Like now is the time to really prepare everybody at your place. And hopefully you never need it, and you did a good preparation. Who knows? Heather,
Okay.
back
Yep.
to
No,
you.
Martin's just saying that and in the chat box, no questions right now. So we've got somebody that says staff's iPhone. I don't know who that is, but you might know who you are. So if you're able and want to unmute yourself, we can hear from you now.
Oh,
Hi, go ahead.
no, this isn't the iPhone issue. This is Linda. So,
Oh, okay.
I just wanted to share a situation that I had today in regards to getting like imaging done from a portable radiology company. And they were doing imaging in a COVID nursing home in the London area. And they were kind enough to share that with us before we accepted them coming into a home that was on suspected outbreak, but we have no confirmed cases. So the feedback I got from this imaging company is that 50% of his clientele, I guess, were the homes that he was going into were allowing him to go in, and the other 50% weren't. So I was just wondering about anybody's feedback on that.
Anybody that has experienced that?
Yeah, hi, it's Shannon. Some of my homes have made a personal decision not to have STL imaging come and do portable imaging during this time, but the majority have been okay with it. There's a lot of benefit from that in terms of ER diversion. So for me, what we're noticing amongst our 22 homes is quite a variance, with I'd say maybe about 2 or 3 of the 22 deciding not to have imaging as their own personal decision.
Thank you for that.
Okay, and then I think that's helpful. And then Suzanne's iPhone, it says. Suzanne, do you want to go ahead?
I thought that was Suzanne.
And I don't, was that Suzanne?
No, that was
No, it's
Linda.
Linda. Yeah.
Yeah, that was Linda.
Oh, that was Linda. Oh, right.
Yes.
Yeah. Okay, well, I'm not hearing from her, so I'm just checking to see, did I forget anybody? I'm sorry, I'm practicing with all of you, so I'm sorry if I've missed you.
I saw Deirdre. Deirdre, did you have any questions?
Well, there was just one, and that was regarding nurse practitioners working in only one home. That was
which I think Doris has addressed. Yeah,
and that has been addressed since. So that was a question from a while ago. And also, I just saw a comment from Jean Benton, and she was looking for information on how to decrease medication passes to once per day.
Medication passes?
Yes.
Yeah. Does anybody have any resources that they can share related to that?
1 second. Medication passes meaning seniors going out?
No.
No, the medication
going mad.
Doris,
What do you mean?
Instead of QID, maybe going to OD for pain medication, blood pressure medication.
Okay. I thought I was going to go completely mad now. Anybody that has experience with that?
I think Holland Christian Homes has some information, but Rebecca could probably speak to that. I'm not sure.
No, my husband has been decreasing his med passes not to once a day. I think Jonathan, your goal's been to twice a day. Yeah. So definitely not with pain medication, but just the medications like vitamins, decreasing the unnecessary medications.
Maybe that's something that we could look into, Doris. Perhaps we should be asking about, how to effectively manage.
Let's do, and Heather, this is one of those issues that we can discuss with the dogs,
because they're wanting to do the same. Yeah.
With the dogs at the OMA. And the other thing, Heather, is let's think about opening this also to some of the dogs, if they want, of the dogs that work in long-term care. I meant to do that before because OMA is not doing this type of thing, and they may appreciate that.
Okay.
Hi, it's Shannon. Sorry, we worked with pharmacy really closely on that project to reduce med passes. We got most of our residents down to twice a day. Anyway, yeah, it's been really quite wonderful. And then we just started it with the next medication strip. So exactly what, sorry, one of the other individuals is saying about the clustering the vitamins and, you know, there's a lot of even creams and that could probably be PRN, things like that, like really getting down to the sort of more essentials. And it's been wonderful. The nurses have really appreciated it already. And yeah, it's been great, but pharmacy was instrumental in doing that.
I think that's very smart.
Mhm.
That's very smart. Heather, this could be a joint statement with the OMA and OPA, like the one that I did with them on the drug that is being tested.
Yeah. Okay,
That's a
super.
great idea,
Now, I'm
yeah.
sorry, everybody. I kind of lost track what's in the chat box. I don't know, Irma Jean, if you've been keeping an eye, or Christy, Catherine, or any of our other colleagues.
I think we're pretty good. There's comments in answer to questions about, you know, PSWs in Quebec being paid a little bit more. Yeah, I think we're pretty well okay. And I think someone picked up Jean's question. So
Jean, I have a question. It's Rebecca.
Okay.
So Holland Christian Homes is really struggling with staff. And I noticed in the news that there was a home in California, albeit America, that the long-term care staff walked out completely.
So there is, I really don't want to get more into this. There is Via Nurse, there is a lot of people that are ready to work. You guys need to use it. I'm not sure what's the barrier here. Can you explain us what's the barrier? Because we have been talking about this is in every single report, it's in every single communication.
I appreciate that. I do appreciate that, Doris.
So what do we do?
If the staff walk out, all of them, what's the plan?
No, the plan is that you build now surge capacity. So if the staff walk out, you will have other staff. You know what I mean? The staff will not walk out if they see that there is surge capacity. It goes hand by hand. We can control only what we can control, right? There are places, and in the US happen, and the more they will see it here, the more it will happen, that staff will walk out. You know, we just heard also Wendy said that the PSWs call and said, sorry, I'm not coming. So now is the time. And the same that we are saying to you, I'm saying to the hospitals in ICUs. There is people waiting to be hired. Please do. Have at least 20% more than what you need. And then you will, and then you can, you know, have it. And then if others walk out or don't come, they will not walk out. They will just say to you, I can't come because of whatever. Then you will have that surge capacity. It's totally critical. So please, Heather, if you can facilitate this link again, because Kerry will send right away people, but they need to hire them. We hear from people that they put the name and they're not being called or hired. And this is across the province. We heard from a person that actually is a clinical instructor in long-term care. He's fantastic and in the north. And he said to me, I will do PSW, I will do ADN, I will do this, I will do that. No, everybody says, well, let me interview you. Fine, interview me. He says, and still they don't call. So there are two sides to the coin. There is lots of people available. No other province has the luxury that you guys are having. Use it, please. Use it, use it, use it.
Yeah.
You know, I think the other thing is we have to understand in some jurisdictions, there's no active and visible lobby. And I think certainly here, with work Doris is doing, with work RNAO is doing, with the fact that you can see there is responsiveness to the messages Doris gets out, even if she has to go to social media. So I'm sensing that there isn't that feeling that we're out there all alone.
It's true, Imagine. That's a very important point. A very
Yeah.
important
Yeah.
point.
No, I think, and even the message you're giving of the duty to serve must be matched by the duty to protect. And that's what people need to hear, that who are there, that's what we're pushing for.
The duty to care must match by the duty to protect. Let's use the same, and I will create actually a hashtag with that.
Yeah.
But I don't want, I don't want to ramp on that, because I don't want people to also misinterpret
Yeah.
that we are saying abandon care.
No.
So, but going back to the specific of your nursing home, please do not tell us you're short staffed, because we are here. And once you tell us and fill the form, have you filled the form, by the way? Yes? Yes? Then Heather, can you facilitate with Carrie? Give a call to Carrie after, or send me the information and I will call Carrie, and then make sure you guys hire the people. If I was one of you, I would hire a 30% surge capacity, because there's no way in this situation that you will end up in trouble for budget issues. Just 30% surge capacity. And people will feel different even by seeing that there are more hands.
There's a couple more comments in the chat area about using the letter template RNAO provided from the medical director. It was super helpful. It said could have added the info on plan to reduce meds so family would have a heads up, because they are often resistant to reducing meds in my practice, even with BPG evidence. I don't know if there's any more to say on that. Jean is saying, does anyone have an established process outlining caring for the COVID infected person for RPNs and for PSWs?
Tell me more. I'm not sure.
Yeah,
well,
Jean.
except of the surgical mask and gowning if the person is positive. Tell me more what you mean. You mean in regular terms, or you mean during palliative care? Tell me more what you mean, please, Jean.
Okay, can you hear me?
Yeah.
Okay, I'm thinking more of they are our first eyes at the bedside, and what I get worried about is they notice a change in the person, but it doesn't make its way to me until later in the day, and they say, oh, by the way, and then there are certain parameters that need to be assessed as RPNs at the bedside, so that they're calling myself or they're calling the doctor earlier on than later on.
Good. So Heather, that's another guideline we can do, Heather.
Yeah, I've looked at the literature, and I mean, the big one.
Don't worry, Jean, don't worry. We will develop a guideline and then we can run it by some of you. A guideline for, I will be careful. I would say in the guideline, Heather, I will put NP, RN, RPN, and PSW, so the RPNs don't get upset that we are paralleling them with PSWs. Put the 4, responsibility of each one, kind of agreed.
And I think this, Doris, ties in with the kind of appropriate education we need to be providing. I mean, presently, when I have people with congestive heart failure or COPD, I talk extensively with the PSWs saying, what I want you to, we're diuresing or we're doing something with that individual, and this is what I want you watching for and reporting.
Excellent.
So
those
it's
are
that
those are the pieces, Jean, that you will help us populate. We will develop a grid. We will put with the LTC coordinators what we think. Then a couple of MPs, you being one, can populate more, and then we can run it by OMA. So they also, and we can send it with joint logos as we did another one. It was completely done by RNO, then they shape some pieces and then we send it out.
Yeah, because I mean, I'm pretty well organized on the palliative stuff, but it's that interim in between.
Excellent.
Yeah.
So basically, Heather, so it will be caring for a resident that is COVID-19 positive. Let's turn it to the resident, not the COVID-19, right? Let's
Right.
keep the
Yeah.
humanity in it. And let's do agree with, I would say, physician/NP, then RN, then RPN, then PSW. You can turn it upside down if you want, because the PSWs are the most, and they are kind of the eyes. Maybe turn it upside down, so the PSWs, you know, feel important, and they are the eyes on the field, and word it in such a way that they feel important, that they are balance the eyes and the ears on the field.
Yep.
So
And
that
Jean,
they-
really what you're wanting to do is get a big a sense of, you know, sort of when to escalate to you. Is that correct?
And what are the signs, Heather?
Yeah. Okay.
Yeah,
I
I
just
mean,
want to.
they are the ones that are monitoring, okay? And I know we're very focused on the palliative side, and we're well organized that way. What we're not organized is that interim step.
Okay.
You know, and I think we have to give guidance as to, you know, what each of those categories should be when they're providing care to these individuals, watching out for and
I
reporting.
think that's excellent. I think that's excellent. We can
thank
do,
you.
yeah, very
And
good.
also what comes from you is that timing, like what's urgent to get to me and what's end of day.
Yeah, very good.
It's
So yeah, so it can be, Heather, it can be coded with red, meaning urgent, with yellow, meaning can wait a couple of hours, and with green, tell me at the change of shift. I love it. That is critical. If we can do it really early next week, that would be fantastic. If you have some thoughts, Jean, in your spare time, send us, but if not, wait. We will send you some.
Okay, no, I'm working on it.
No, we will send you something, yeah.
Yeah, it's Heather Woodbeck. I just wanted to say that the ministry's testing document, if you need something like right now for over the weekend, the testing document lays out the symptoms for asymptomatic people really nicely.
Can you send it to Heather so we can, or to Kyle?
Yeah, I'll send it that part to Kyle, and then we'll work on a really nice one on Monday.
Fantastic. If you have spare time and you want to put thoughts, absolutely, that will be good. But excuse me, what's going on? Can you mute, please, whoever has the phone? Kyle, can you mute? Heather, let's make sure that by end of Monday that protocol is done, and that then we get it to Jean to review so that we can send it to the OMA and we can put it out on Tuesday. That's really critical because we are, yeah. That this is the type of thing that I think is so very helpful for us, because then you all will have it. Any other pieces that you think are needed like this? Like other protocols? To then pieces. To then piece. Imagine, can we let piece for a
Okay,
minute?
yes. I was just looking at what was in the chat.
To then piece, any more questions or protocols that you think are necessary? Okay, I don't see any. So Imagine you had another issue, or anybody else?
Well, I just wanted to raise the comment that you were making, Deirdre, about the resource for palliative care orders. I see people are sending you emails. Do you want us to put that on the site?
Well, I think so. It's very useful. It's a very useful document. It has a lot of information and links to various palliative care resources. But importantly, it has directives for nurse practitioners and for doctors to care for patients who are COVID-19 positive. So it includes palliative care orders, comfort measures, it includes medications to use for dyspnea, for anxiety, for pain. So I think this is a document that should be widely spread and distributed.
Okay, that's great. Thank
Anything else? Heather, anybody else that didn't speak?
Sorry, I was on mute. Not that I can tell, Doris. I think I've got everybody, and Irma Jean's been monitoring the chat, so I think we're good. And anything that we may have missed, we'll follow up with. We'll be reviewing the chat box, and but it looks as if our team has been reviewing too, and they say that we're looking pretty. We look like we've responded to everything.
Okay, we need to do a picture, Heather. Wait, a fake picture because it's not 7:30. We ask that everybody takes the elements. And Kyle, you can put everybody in picture mode. We will do a, who is doing a picture?
I'll take a picture.
Oh, there you go. Oh.
Everybody, where are the other 20?
Put your videos on, everybody that can, so we can take a picture of you.
Yeah, and off mute.
Yeah. Yes, that's true, off mute. So there is big noise.
Okay, now I'm doing a video, not just a picture.
Oh, that's even better. That's quality improvement on the spot. Look, I can even scratch my face with this one.
Don't touch your face, Doris.
Okay, not in the picture at least. Okay.
And Jean, I have to say, we're seeing a picture of you and you look 40, for heaven's sakes.
Thank you. Thank you, yeah.
Doesn't make nice noise.
Okay, let's give it a go.
Okay, are we ready? Linda, some of you are on mute. Heather, Linda, Sue, you gotta come off mute.
Okay.
Great. Beverly, off mute. Okay, 1, 2, 3. Doris, you ready? 1, 2, 3. Oh!
Everybody.
Thank you, healthcare workers.
So many things.
Oh dear, it's not a very good video, but anyway, I'll try my best. Okay.
That was for you guys to say thank you to you. To you, thank you for all the work you are doing. You are simply inspiring, truly, truly. From all of us at Areneo, we are at your service. Thank you, guys.
Bye, everybody.
Happy Easter.
Right.
Happy Easter. Bye-bye.
Yeah, happy
Yes.
Easter.
Yes, if you celebrate, happy Easter. Bye-bye and Passover.
Yep. Lots of holidays this weekend. Stay
Yes.
home.